Hello, I'm Dr. Daniel Kuritzkes from Brigham and Women's Hospital in Boston, Massachusetts. And in the next few minutes, I'm going to be giving you an update on the problem of drug resistance and PrEP. These are my disclosures. Here's an outline of my talk. I'll discuss concerns about PrEP and antiretroviral drug resistance, provide some data on the incidence of drug resistance in the setting of PrEP use, talk about the effectiveness of PrEP against drug-resistant virus, and the potential for resistance with long-acting PrEP, and then some conclusions. By way of background, we know that oral PrEP is highly effective at preventing the transmission of HIV, but concerns have been raised about resistance in the setting of PrEP, particularly because drugs used for PrEP are either the same drugs or in the same class as those used for antiretroviral therapy. The selection of drug resistance after PrEP failure could therefore compromise the efficacy of future antiretroviral therapy for patients in whom PrEP fails. Overall, the prevalence of pre-existing drug resistance could also be increased by the use of PrEP. Well, what are the potential risks for drug resistance? PrEP regimens could select for drug resistance in cases where PrEP fails. Intermittent adherence could also allow infection to occur during a time when a patient is not taking PrEP, and then inadvertently be receiving suboptimal antiretroviral therapy when a 2-drug or 1-drug PrEP regimen is reinitiated in the setting of unrecognized HIV infection. PrEP could also select for transmission of resistant variants from partners with failing treatment or pre-existing drug-resistant variants, despite the use of PrEP. And long-acting PrEP formulations raise new concerns regarding the possible selection of drug-resistant virus. What do we know about resistance to common PrEP drugs? Well, drugs currently approved for PrEP require only a single mutation to confer a high level of resistance. In the case of tenofovir, that's the K65R mutation. And in the case of emtricitabine, that's the 184I or V mutation, which also confers resistance to lamivudine. The low genetic barrier could be mitigated by the fitness costs of resistance mutations. We know that there is a low prevalence in virus populations of these mutations in untreated persons. And some mutations, such as the M184V mutation, increase susceptibility to other drugs, such as tenofovir, and may actually counteract the problem of resistance to FTC or 3TC. In addition, high tissue concentrations might provide an added pharmacologic barrier to emergence of resistant virus. What about antiretroviral drug resistance after PrEP failure? A systematic review conducted by Gibas and colleagues identified nearly 700 participants with HIV seroconversion in 13 PrEP trials that used either TDF monotherapy or TDF together with FTC. 77 of these were individuals who had acute infection at the time of enrollment into the trials that was diagnosed retrospectively, and more than 600 had incident infection during follow-up. Drug resistance overall was infrequent. It occurred in 18 of 77 participants with acute infection, nearly a quarter of them, but in only 3%, or 19 out of more than 600 participants with incident infection. So very clearly, the risk of drug resistance is greatest in PrEP when PrEP is given to people who are already infected but not yet diagnosed. If we look in more detail at resistance in acutely infected participants in PrEP trials, 15 of them had resistance to FTC with an M184V or I mutation, one of whom had actually received placebo, so must have acquired infection from an already resistant virus. 2 had resistance to tenofovir alone with the 65R mutation. 1 had received only TDF, and 1 was receiving TDF and FTC. And 1 participant had resistance to both FTC and tenofovir, and that person was receiving the combination of TDF and FTC. Continuing to look at resistance in PrEP trial participants now with incident infection, 15 of these had resistance to FTC. 4 were actually receiving placebo, so must have acquired resistance somehow after being in the trial, or because they received a resistant virus, transmission of a resistant virus. And 1 was receiving tenofovir alone, so hard to explain in these 5 individuals where the 184V might have come from. 2 had resistance to tenofovir with a K65R mutation, and again, both were receiving placebo, so must have had transmitted resistance. And then 2 had resistance to both FTC and tenofovir, and both were receiving the combination of TDF-FTC. This slide summarizes case reports of drug resistance after PrEP failure, and this is again from that same systematic review by Gibas and colleagues. And you can see that across these 6 reports, there were actually a variety of mutations in addition to mutations at the 184V and K65R sites that suggest that there may have been transmission of other resistant viruses, or that perhaps in some cases individuals had other exposure to antiretroviral therapy. Now, one of the concerns about current PrEP regimens is that there are high rates of K65R after first-line treatment failure in certain settings, particularly in lower and middle-income countries. In a study that we did at McCourt Hospital in Durban, South Africa, nearly 70% of patients failing a tenofovir-containing regimen, first-line regimen, had the K65R at the time of resistance testing. Another study of 1,000 patients conducted by our colleague, Dr. Brij Kumar, in rural or semi-rural KwaZulu-Natal, of 1,000 patients initiating first-line ART, found a 30% prevalence of K65R at treatment failure. Of course, if these individuals transmit those viruses to their partners, that could be a problem if their partners are using tenofovir-containing PrEP. Looking at tenofovir resistance more broadly, the TenoRes group published in The Lancet 4 years ago this survey, and you can see that many of the individuals in whom tenofovir resistance was detected also had coexisting mutations conferring resistance to other drugs, either to FTC and 3TC by presence of the 184V mutation, or mutations that conferred resistance to the non-nucleoside RT inhibitors, or both. And you can see those in the salmon, red, and green colored bars by different region. Now, of course, the K65R mutation, although considered primarily a tenofovir resistance mutation, itself also confers resistance to FTC and 3TC. More recently, the CDC published, I'm sorry, not the CDC, the HPTN published results of HIV drug resistance in US MSM, and you can see that the range of resistance rates varied quite a lot by region, being highest in the southern United States, where more than half of individuals in Birmingham, Alabama had pre-existing resistance, whereas 20 to 30% in other parts of the country had pre-existing resistance. Some of these, most of these were people who were all known to be HIV infected, but may or may not have been on antiretroviral previously. They were not on antiretroviral therapy at the time of this survey because they were all viremic. And the majority of them had testing for integrase inhibitor resistance as well, but not all of them. You can see that INSTI resistance was relatively uncommon compared to resistance to the nucleosides and non-nucleosides. Well, what about the efficacy of treatment of PrEP if there is pre-existing resistance? One study done in macaques looked at a SHIV, that is a chimeric virus that had the HIV reverse transcriptase in an SIV backbone, into which the 184V mutation had been introduced. And you can see that when those monkeys were given a TDF-FTC combination PrEP regimen, all 5 of the control animals became infected, but none of the treated animals became infected, suggesting that this combination remains highly effective in preventing acquisition of infection despite the presence of FTC resistance. Well, what about the efficacy of PrEP in the context of a K65R mutation? In this set of experiments, again, the same idea, SHIV with a 65R mutation introduced into the RT gene. Monkeys received either intermittent FTC TDF PrEP or control and were challenged with a low dose of this mutant virus. And then those that remained uninfected were, after a resting period, challenged with a higher dose. What you can see is that while the monkeys were still protected against acquisition of infection when receiving only a low dose challenge, TDF-containing PrEP was less effective at protecting these monkeys when a higher dose challenge was used, suggesting that the 65R mutation was impairing the efficacy of PrEP. What about the risk of resistance with long-acting PrEP? Long-acting formulations offer the potential advantage for PrEP of infrequent dosing and perhaps better adherence, but the long half-life and extended tail of these formulations carry unknown risks of exposure if the individual is exposed to HIV during a very prolonged tail. Similar concerns may pertain to the broadly neutralizing antibodies with an LS modification that likewise gives them a very long terminal half-life. This slide shows just how long that half-life can be with cabotegravir given by single injection, and you can see that drug is still detectable out to nearly 1 year. Well, we know in the Atlas and Flare studies, in which the combination of cabotegravir and rilpivirine were given as treatment, that among individuals failing on that combination regimen, that cabotegravir resistance can be selected, as illustrated in these individuals from the initial reporting of the Atlas and Flare trials. We also know that in the case of long-acting rilpivirine, which is no longer really being pursued for PrEP, that an individual who had received a rilpivirine injection and then had an exposure to HIV 40 days after that injection became infected with a virus that carried the 101E mutation selected by the continued presence of rilpivirine and needed to be put on a different regimen, non-NNRTI containing, because of the acquisition of resistance. We also know that in the non-human primate model, if the monkeys are challenged with SIV, then given cabotegravir as a single dose a few days after infection, that these monkeys can select cabotegravir resistance, as shown in these data coming out of the CDC. So in conclusion, PrEP may select for drug-resistant virus. To date, the incidence of resistance has fortunately been low. The greatest risk is for persons with unrecognized recent infection who initiate PrEP. FTC resistance seems more likely to emerge than tenofovir resistance, but dual resistance has occasionally been reported. The increasing prevalence of K65R after first-line treatment failure may blunt the efficacy of combination TDF-FTC PrEP. And the prolonged tail of long-acting formulations could pose an additional risk for resistance in persons infected after stopping PrEP. More data will permit better modeling of the risk-benefit ratio of PrEP with respect to resistance. Thank you very much, and I will return this to the moderators.